Once he goes live, we will start, Vasant.
Good afternoon.
Good afternoon.
Good afternoon.
Good afternoon. Good afternoon.
Good afternoon, sir.
Good afternoon, sir. Good afternoon to all of you.
Ma'am, we are live on YouTube.
Yeah, thank you.
Yes.
Vasant sir, shall we start?
Yes, he
please
wants
go
you
ahead.
to start.
Start.
Thank you. Yeah. Hearty welcome. Good afternoon to all for our 5th episode of Academics with Institution. We are back with a very prestigious institute from West Zone, D.Y. Patil Medical College, Hospital and Research Institute, Kolhapur. So hearty welcome to all of you for this 5th episode. At the outset, I would like to welcome our Honorable National President, Dr. Vasant Kalatka, sir. In spite of his busy schedule, he doesn't miss Academics with Institution. Thank you so much for joining in, sir. And I welcome our President-elect, Dr. Neelam Mohan ma'am, who is also traveling. Thank you so much. Both of them are back from Nepal. Thank you so much for joining in. Welcome our immediate past President, Dr. G.V. Basavaraj, sir. Thank you so much. And welcome our Honorary Secretary, Dr. Yogesh Parikh, sir, and National Treasurer, Dr. Atanu Badra, sir, who are traveling. I would like to welcome our respected Chief Guest, Dr. Rakesh Kumar Sharma, sir. Thank you so much for accepting to be our chief guest today, and welcome the whole team of D.Y. Patil Hospital headed by Dr. Nivedita Patil, who has coordinated with me. Thank you so much, ma'am. And I thank all the dignitaries who have joined in, all the teachers. Srinivasan sir is here, and all the great teachers from D.Y. Patil Institute. Thanks to all the faculty and the postgraduates who are presenting today. I would request our National Secretary, Dr. Yogesh Parikh, sir, if you are able to speak few words, request you to speak, sir. Thank you.
Yeah. So thank you, dear Dr. Priya Madam. And here I welcome our ever smiling President, Dr. Vasant Kalatkar, sir, and President-elect, Dr. Neelam Mohan Madam, Dr. G. Basavaraj, sir, and Dr. Atanu Badra, sir, in absentia. Today's chief guest, Dr. Rakesh Kumar, sir, from the Vice Chancellor of the D.Y. Patil Education Society, and Dr. Ramesh Bajaniaji, our VP from the West Zone, Dr. Priya Madam, for the excellent coordination of the this academic institution program with you. So thank you very much for joining all of you. And I welcome our the D.Y. Patil faculty, Dr. Nivedita Patil Madam, Dr. Mohan Patil sir, Dr. Suhas Kulkarni sir, and Dr. Vilas Jadhav sir, and both the PG students. This is the 5th episode of the academics with the institution, and the last year we have completed more than 15 programs, and this is a very well successful, very demanded academic program across the country, and we are enriching with the experience of the medical faculties and the PG students. So thank you very much. Over to PG Priya Madam.
Thank you, sir. I'm happy that we could have you on the program. Request our Honorable National President, Dr. Vasant Kalatka, sir, for your few words.
Yeah, namaste from Nepal. We are in Nepal for this NEPCON, this conference. Tessie just finished mine and Dr. Neelam's lecture. So, respected Dr. Neelam, our President-elect, Dr. Basavaraja, past President, Dr. Yogesh, and Dr. Atanu, and all the senior, all the academic member, all the team member of academic institute. It's really great thing that we are pursuing in spite of all these issues. We are having so many difficulty, but Priya, you are doing a really great work for this thing, and that's why it's continue. I'm really sorry that because of our this Mexico trip and this Nepal trip we got little bit late, but it's never late in academic. We are always on. So I would want to talk about D.Y. Patil Institute. They are always ready in any academics. The team of Dr. Patil, our Vice Chancellor is there. Then Dr. Kulkarni, everything team. That Kolhapur, I saw that college very good academics is always going on. Their OPD is tremendous, and whatsoever work, different sub chapters they are doing. Like Dr. Kulkarni is heading for allergy, and every chapter it's working. So whenever any thing we want in Kolhapur, that DY Patil का नाम आ जाता है. So thank you, DY Patil team, for your this academic session, and let us continue. Let us learning should be continue, and next episode will be little bit early. So Priya, we will take care of that, and thank you once again. I wish.
Thank you. Thank you.
Thank
Thank you so much, sir, for keeping the IAP flag high, taking to greater heights. Thank you. Thank you so much, sir. I would now request our President-elect, Dr. Neela Mohan ma'am, who is also traveling along with Dr. Vasan sir,
पर आ रहा नहीं तो मेरी इससे
for your few words, if the
इससे बात
network
करो.
allows.
You know.
Right. Thank you so much. It is a pleasure to be just supporting this event. And when I was actually looking to DY Patil, I mean, they have so many branches that you have to keep wondering which one is what. So I need to visit every place to decide. But having said that, I can only say that, yes, it's a lovely university which is doing work in medical and engineering, healthcare that you're providing to children is pretty good. I think in 1989, it's been now almost 25 years, 30 years that DY Patil Medical College is there. And the chairperson, I'm very happy to see that the Dr. Sharma, who's been involved in the health activities in them, along with the seniors who have joined Dr. Vasan, Dr. Baswaraja, Dr. Yogesh, Atanu, and the VP, Dr. Ramesh, all for joining and going to present, though we don't know what exactly is the case, but I'm sure under the guidance of Nivedita Mohan Patil and Suhas Kulkarni, along with Jadhav, the team would have come up with something interesting, and we wish you all the best at Team University to scale more heights in empowering students with fun and making it a great event. We look forward to listening as much. Thank you.
Thank you. Thank you. Thank you so much, ma'am. It means a lot
Dr.
to all of
Rakesh,
us.
your room is very interesting, your room. I think I should be there once again.
Thank you. Thank you, ma'am. Now I would request our immediate past president, Dr. Basavaraj sir, for your thoughts on DY Patil Institute.
Thank you very much, Dr. Priya, all the respected dignitaries on the dais and off the screen. And the most important is IAP is very much committed to the taking the academics to the greater heights. Look at our Honorable President, Dr. Vasant Kalatkarji, in spite of a lot of IAP engagement along with our President-elect, Dr. Neelam Mohanji, how much they are committed to the academics and making the academics to grow not only in India and across the world, where our Honorable President Dr. Vasant Kalatarji and Neelam Mohanji were very instrumental in taking IAP to the behind the border. And of course, our senior vice president led by Dr. Ramesh Bajania ji, who has been very, very instrumental in coordination with our office led by Honorary Secretary General Professor Yogesh Parikh and Dr. Atanu Badra. All of them are coordinating, working in tandem with all the executive board members to take the academics, especially the West Zone. DY Patil is one of the best institute I have seen it, in especially if you visit their simulation lab is one of the best lab in the country, where I visited personally along with Dr. Nivedita Patil, professor and head of the department, Dr. Mohan Patil ji, and of course Vilas Jadhav sir. And all this was possible mainly Suhas Kulkarni sir. All this is possible mainly because of a great support from Vice Chancellor Rakesh Sharma ji and all the administration who has been doing a great work at the DY Patil. DY Patil, which is known for academic excellence. In fact, I was interacted almost one day I was there in a DY Patil, interacted with the chairman of a DY Patil. all the time, the one of the thing which is emerges from the conversation is how to make the academics and not only the making the academics for excellence and also serving the poor people in and around the Kolhapur. That's the beauty of a Kolhapur Medical College administration, which is doing a great work in terms of academics, in terms of a patient care, in terms of a charity and organization. So where the institution can do a lot of things. So thanks to the Department of Pediatrics of DY Patil and contributing immensely to our IAP also. The best wishes for the today's program for the postgraduates and all the faculties.
Thank you. Thank you so much, sir, for briefing about DY Patil Institute to all of us. Thank you for your presence. I would now request our Senior Vice President of West Zone, Dr. Ramesh Bajania, sir, for your words and to introduce our respected chief guest, Professor Rakesh Kumar Sharma, sir.
Thank you, Priya. Good afternoon, beloved President Vasant Kharatkar, sir, President-elect Neelam ma'am, past President Basav, sir, under whose tenure this very important academic program was introduced. And it was magnanimity on the part of our current president that he continued such a popular program. Good afternoon, Dr. Yogesh Parikh, sir. Today, it gives me a great pride in introducing a person. When I looked at his CV, I really felt that he has lived a complete life. Dr. Rakesh Sharma is an alumnus of IGMC Shimla and Armed Forces Medical College, Pune, and has served in Army Medical Corps for 16 years. He has served in various capacities, both as a teacher as well as a medical administrator. He has been Dean of Medical Colleges in India and abroad for more than 12 years by now. Presently, he is serving, as Sir said, as the Vice Chancellor of DY Patil Education Society, Deemed University, Kolhapur. He is an avid researcher and has published in reputed national and international journals. He is a founder member of the Independent Ethics Committee for Research on Human Beings Movement. He is member of National Academy of Medical Science and has also served as member of the governing body of ICMR. He's a vivid traveler and extensively he has traveled, especially in African continent, to learn and share views on internationalization of medical education. Plus, he is a member of various professional and philanthropic bodies and actively participates in state, national, and international conferences in various capacities as a delegate, invited faculty, and chairperson. So I welcome Dr. Rakesh Kumar Sharma ji to this very academic program of our flagship Central IIP. I congratulate Dr. DY Patil University for hosting particularly this academic with institution program. And both the PG students, they deserve a loud round of applause. So not taking much of the time, over to Priya for continuation of this academic program. Thank you.
Thank you. Thank you so much, sir. I would now request our respected chief guest, sir, for your message.
Thank you very much, madam. First of all, I must thank Dr. Ramesh Bajania for the kind introduction. Respected Dr. Vasant Kharatkar, President, Indian Academy of Pediatrics, Dr. Yogesh Parikh, Secretary General, Office Bearers of the IAP, Dr. Neelam Mohan, Dr. Bhaswaraj, Dr. Jagdish Chenappa, my colleagues from DY Patil Education Society, Deemed University, Dr. Nivedita Patil, Dr. Mohan Patil, Dr. Suhas Kulkarni, and Dr. Vilas Jadhav. Ladies and gentlemen, distinguished members of the academic fraternity and dear PG students. It is truly an honor and privilege to attend this program in the presence of illustrious gathering of dedicated pediatricians and future healthcare leaders. Founded in 1963, the Indian Academy of Pediatrics has consistently exemplified the spirit of commitment, innovation, and excellence in advancing child healthcare across our nation. Your efforts in establishing platforms like Academics with Institution exemplify your unwavering commitment to education and professional growth. It is with great pride and honor that I take this as an opportunity to give you an overview of DY Patil Education Society, Deemed University, Kolhapur, an institution known for nurturing excellence in academics, research, and holistic development for the last 20 years. From its inception in 2005 as a health science university to its evolution into the multidisciplinary hub of learning, our institution has continually embraced innovation and excellence in higher education. We take immense pride in the recognition we have secured at national level. Our accreditation history speaks volumes, achieving NAC A++ grade with consistent dedication to quality, the ISO certification, the NABH and NABL accreditation underscores our commitment to maintaining rigorous standards in academic and healthcare excellence. These achievements firmly place us among the most respected universities in India. Our academic endeavors align with the National Education Policy NEP 2020, signaling our move towards offering interdisciplinary and multidisciplinary programs. Our pioneering initiatives, such as Maharashtra's first ever cadaveric bioskill lab and state-of-the-art simulation and skill center, with over 195 training models, equip students to tackle real-world challenges with practical expertise. As a university, our commitment extends beyond the classroom. By focusing on impactful research and innovation, we have registered 52 patents, more than 195 Scopus publications, and hosted international research collaborations. Most notably are our research incubation through APJ Abdul Kalam Incubation Center, which fosters startup and the innovation that it addresses. We have earned accolades from institutions such as SERB Tetra National Innovation Award. Our vision is to be a world-class institution, and this drives every member of our academic community to excel. Together, we forge a path of collaboration, compassion, and excellence. In closing, I want to commend the Indian Academy of Pediatrics for its exemplary dedication over the decades. Your collective efforts stand as a testament to the power of knowledge, collaboration, and unwavering commitment to child healthcare. Now, let us continue this noble journey with renewed enthusiasm and determination. And here I would like to mention the visit of Dr. Bhaswaraj, and I had the privilege of interacting with him for a short time. At that time, I was the Dean of the Medical College. I welcome all of you senior dignitaries to visit our institution once again so that we can have more input from you so that we can improve further. Thank you very much, sir. Thank you for inviting me over.
Thank you. Thank you so much, sir. In the pursuit of excellence, all the efforts taken by you and the Department of Pediatrics, I think kudos to your department also, ma'am. Thank you so much for accepting to be participating in today's session in Academics with the Institution. I now request our coordinator, Dr. Amol Pawar, who chose D.Y. Patil Hospital for Academics with the Institution today's session. Thank you so much for coordinating. I would request you to introduce our Chief Chairperson, Dr. Nivedita Patil, ma'am. Over to you.
Thank you, Priya ma'am, for your words. First of all, I welcome President Dr. Vasant Khaladkar sir, President-elect ma'am, Dr. Neelam Mohan ma'am, Dr. Jeev Basavaraja sir, Yogesh Parikh sir, Atanu Badra sir, Singarolu sir, Devendra Sarin sir, and all the dignitaries, Dr. Srinivasan sir, who doesn't miss these sessions, Dr. Jalil Ahmed sir, and also all the executive boards members from West Zone as well as all the other zones also. Also, I welcome my senior colleagues and friends from D.Y. Patil Institute, Dr. Nivedita Patil ma'am, HOD, then Dr. Suhas Kulkarni sir, Dr. Mohan Patil sir, Dr. Vilas Jadhav sir, and Dr. today's guest, Dr. Rakesh Sharma sir, Vice Chancellor of D.Y. Patil Institute, and all the attendees. So my job is to introduce my dear friend, senior friend from Kolhapur, Dr. Nivedita Patil ma'am. She has done MD Pediatric and she is also fellow of neonatal. She has also done the neonatal fellowship. Then she's HOD and professor at D.Y. Patil Institute. Then in academic excellence, she is UG and PG teacher since last 22 years. She is faculty for NRP, FGM, then advanced NRP, ALS, BLS, then RTI-GEM, ILIP and vaccinology modules of action plan of Central IIP. She was also faculty at various state and national conferences. She is currently chairman of Board of Studies and member of Academic Council of D.Y. Patil University in Kolhapur. She has been secretary of Kolhapur Academy of Pediatrics in 2013 and also president in 2017. Currently, she is senior colleague in executive board of Maharashtra IIP. She is joint secretary, and also in October there is Mahapedicon in Kolhapur, and she is heading that conference as an organizing secretary. Her areas of interest are neonatology, emergency pediatrics, then critical care and infectious disease. And she has various publications, 20 national and 5 international publications with Pioneer, MSN, and article in PubMed in 2020. So thank you for accepting, and over to you, Priya ma'am.
Over to our chairperson, Dr. Nivedita ma'am.
Nivedita ma'am, yes.
Thank you, Amol, for those kind words. Am I audible?
Yes.
Yes. I'm just sharing my slides. Good afternoon, everyone. Thank you, Dr. Vasant Khalatkar, IIP President, Dr. G.V. Basavaraja sir, who has visited our NICU during inauguration, Dr. Neelam Mohan madam, Dr. Yogesh Parikh, Atanu Bhadra sir, Dr. Ramesh Bajania, and all vice presidents of IIP, Dr. Jagdish Chenappa, Chief Advisor of this program, Dr. Priya Shivalli, National Coordinator, for giving us this opportunity to present our institution. Are my slides visible?
Yes, ma'am.
Yeah. Dr. D.Y. Patil Medical College Hospital and Research Institute, Kolhapur is located in the city of Kolhapur in Western Maharashtra. It's also known as Dakshin Kashi. The slides are not changing. It is also known as Dakshin Kashi, the land blessed by goddess Mahalakshmi. From there. Okay. Now it is changing. Make full screen. So the D.Y. Patil Hospital is a tertiary care hospital located over 26, spread over 26. This is not working. Are my slides visible now?
Shared it, ma'am.
Yeah. Are the slides visible?
No, not shared.
No.
Yes, you can continue.
So Dr. D.Y. Patil Medical College Hospital and Research Institute is located in the city of Kolhapur in Western Maharashtra, also known as Dakshin Kashi. Change the slide. You can change from there.
Ma'am, any difficulty you want us to share from our side?
We are trying one. Just a minute. Give me a minute.
Okay.
You're connected.
Alternatively, you can just share your slides to the central office at IIP. They can share from there.
Join through other device.
Yes.
Now is it seen?
Seen, but try changing the
Just try
slide.
to move the slides.
Move slide.
Move the slide.
Next slide.
But you can share directly from any laptop instead of the projector. Directly from the laptop you can.
What is this?
You have to log in from the laptop.
I'm joining from other laptop.
Yeah,
Other
please,
device.
Yes.
Yes, you can continue, ma'am. You have to mute one.
Echo is there.
Otherwise it will echo.
Slideshow here, na?
Echo is there, madam.
Put off the other device.
Please mute one of the devices.
Yes, they are doing.
Disconnect. Hello?
Yes, continue, ma'am.
No, echo is there.
Ma'am, if you can mute one of the devices.
You have to close one of the
The
devices.
volume also less of that device. One device with less volume and mute it.
Is my voice clear now?
Yes.
Now clear.
Mute.
Yes. Please continue.
Yes. Sorry for the delay. Still there is echo.
Still echo.
Put off that screen. Put off this screen. Hello?
No, echo is there.
You have to
You
put
have to
off the
close
smart
one
screen.
device, ma'am.
Yeah, switch off. Okay. Is my voice clear now?
Yes, yes.
Yes. Try changing slide, ma'am. Move the slide. Move the slide.
The problem we can see still, on you on a two
If
screen.
anybody else can
See,
join, share
I
the
can.
slides, you can start presenting.
Vilas Jadhav, sir, can you share the slides?
Why not? Why not?
Yeah, you can start, sir.
Ma'am, Nivedita, ma'am, please share your slides to Vilas Jadhav, sir.
Okay.
So that he
Can you see my screen now?
Yes,
Yeah, it is
Make it
visible.
full
Yes.
screen.
No. But we have to start with Nivedita, ma'am.
No problem is, I'll tell you, she is still, we can see still, she's logged in from two devices. She has to switch off one.
Nivedita, ma'am, close one device.
See, we can see her in two laptops. One is Chandra Tejas and one is DY Patil Hospital. So switch off one of it.
Switch off this DY Patil Hospital.
Yeah, perfect.
ये चूस बंद कर दो इसमें क्या है
Share the PPT again.
Hello.
We can start with either research or keynote if it is getting time, ma'am.
Logging through other.
Yeah, if Dr. Vilas Jadhav sir can start, no problem.
That's fine.
Actually,
if you
actually,
say,
Priya ma'am, the whatever the institute history is there,
Yeah, that we can have, no problem, whenever ma'am is ready. Otherwise, we'll be losing out on time. That's Vilas sir, you can.
Vilas sir, please start your topic.
Fine. That should not be problem. You tell me now, am I audible and
visible? Audible, slides visible, make it full screen.
Great, I'll do that. Okay. Is it fine?
Yes, great.
Yes, please.
Yeah, good afternoon all. On behalf of Dr. D.Y. Patil Hospital and Research Center, Kolhapur, I sincerely, I'm grateful to you all IFA office bearers from center, from Maharashtra state for considering us on this national platform. This is one of the prestigious, platform to share with. So today's talk, I'll be sharing my clinical clues that I have, developed over the years to identify movement disorder and diagnose it. It will be a case-based discussion. So we'll start with the case. This is 6 years old who has acute onset head deviation to right, abduction extension of left hand, and a flexion adduction of right hand. And this is since only last 2 hours. Everything was normal, birth details normal, development is normal. So before, heading for any diagnosis of any movement disorder, I think this is the crux of the all talk. This slide is very important slide. We need to have some clinical handles that will tell you that this is a type of movement disorder and underlying etiology. So if you know these 5 handles or clinical clues, either solo or in combination with one another, they'll help you to diagnose a movement disorder. How? Let's see. We'll come back to this case which had acute onset, since last 2 hours, movement disorder. And once the first handle we got from his mother, that mother said, well, he had 2 episodes of vomiting and she had given domperidone. Now you know that what exactly it is. So important is a history. The second one is what type of, or what is the pattern of onset, whether it's acute, whether it's insidious, whether it's, episodic. So that pattern here, it is acute one. And the type of movement disorder is a dystonia. Now, what is dystonia? Most of the students, especially, they confuse the dystonia between spasticity and rigidity. The clinical clues, I'll give you that. In a child who is having dystonia, there is a muscle spasm, and that muscle spasm leads to the twisting or the alteration of position of that joint. When you have spasticity or a rigidity, the natural position of the joint will be maintained either in the very hyperflexion or hyperextension. But in dystonia, it is twisted. So any spasm with a twisting is a dystonia. Keep this in mind. The second clue for dystonia is dystonia changes with posture. When you find that dystonia is more in, say, supine position, and the moment you put child in the prone position, the dystonia disappears or becomes less. That's the dystonia. While your spasticity or your rigidity does not. So this child obviously has acute dystonic reaction, also called as a extrapyramidal reaction to domperidone. No investigations are needed. So, which are the clinical scenarios you will face in your office practice with the acute onset dystonia apart from extrapyramidal reaction? Is the first example is a tetany. This girl who has a bilateral typical carpopedal spasm, which you can clearly you should not miss, and the dystonic posturing of the both lower limbs, bilateral carpopedal spasm. She has a positive choke stick sign, and you can confirm with the serum calcium level. So it's a hypocalcemic tetany, one of the example of a dystonia, acute dystonia. Some of the viral infections, especially those affecting basal ganglia, will cause acute onset dystonia. Child will be encephalopathic following a simple febrile illness. CSF will be a contributor to that. The most important thing is a MRI brain. So MRI brain, it shows a bilateral. If it shows bilateral, bilateral striatal. Can you hear me? I just muted my laptop. It's causing lots of
Yes, you're
music.
audible.
So bilateral striatal hyperintensis on T2 and flare images will be seen in influenza, mumps, mycoplasma encephalitis, and the close difference will be immune-mediated anti-dopamine receptor 2 encephalitis and thiamine biotin responsive basal ganglia disease. Acute dystonia also is seen with immune-mediated encephalopathy like acute necrotizing encephalopathy, acute necrotizing encephalitis. The clinical clue for this disorder is, of course, there is encephalopathy which follows febrile illness, but you have a raised CSF proteins and a deranged liver enzymes. So if you have acute onset deterioration following febrile illness with a raised liver enzymes and a raised CSF proteins, ask for imaging. The diagnosis will be there, bilateral thalamic hyperintensities with some hemorrhagic foci. So that is called as acute necrotizing encephalopathy, where you can have a dystonia as a acute onset, especially a decerebrate rigidity. So another example for acute dystonia in your office practice will be an acute onset stroke. Whether it could be traumatic, it could be vasculitis. You have a hemidystonia. Usually the stroke or any basal ganglia tumor, they have a hemidystonia rather than a bilateral dystonia. It's usually unilateral stroke. So only genetic dystonia which will have an acute onset is this. This is called as a rapid onset Parkinsonism dystonia syndrome. Within few days or a week, the children develop a facial dystonia and rapidly spreads to the body. So everything will, clinical clue for this will be everything will be normal. All lab parameters including CSF, MRI, everything will be normal, and the facial dystonia and a positive family history will give you the clue that this is rapid onset Parkinsonism dystonia syndrome. Now we'll see the insidious onset dystonias, which can be seen in your office practices. The commonest chronic dystonia is a static insult where you have lots of cystic encephalomalacia, hypoxia. Children are globally delayed, and MRI clinches the diagnosis. And so the another commonest condition where you have a dystonia along with a dyskinesia like this child. The clinical clues for this is a history of hyperbilirubinemia at birth. You have a upward gaze restriction. All connectric babies will have, that's a clinical clue for you. Upward gaze restriction, they can't look up, and there will be a impaired hearing, sensory neural hearing loss. So if you have these two combination with history of hyperbilirubinemia, upward gaze restriction, and impaired hearing, MRI showing bilateral called globus pallidus hyperintension like this, then you don't have to work him up further. This is a connectress. So another example for insidious onset dystonia in early infancy metabolic disorder is this glutaric aciduria type 1. How do you pick it up clinically? Any child with a dystonia of long-standing dystonia with a large head, and a dystonia with a normal birth events, unlikely to be anything else apart from the glutaric aciduria type 1. So if you image these children, you will have this bat wing appearance or prominent temporal atrophy, temporal lobe atrophy. That's the hallmark of glutaric aciduria type 1. There are a few more metabolic disorders which will present with dystonia. One is this Leishman syndrome. Obviously, the clinical clue is self-mutilating disorders. See this lips. Lips are totally, bitten by this child. So any dystonia with self-mutilating disorder is nothing else. It's a Leishman syndrome. You have to do a serum uric acid level and, if needed, exome sequencing. Neuroferritinopathies will have dystonia. Only thing is the imaging will tell you that this is a neuroferritinopathies, where the classic sign is eye of tiger, where you have this globus pallidus hyperintensity and the central hypointensity, the peripheral hypointensity. This is PCAN or PLAN, FAN, whatever it is. But the clinical clue is imaging. Any dystonic child with normal birth details, always image. The little late in adolescent period, Wilson can present with a severe dystonia along with some psychiatric illness, positive calf ring, and MRI showing bilateral striatal and thalamic hyperintensities. So keep these things in mind when you are looking for the dystonia. This slide, don't forget, when you have a child who has a insidious onset dystonia but normal imaging, everything will be normal. Child will be normal prior to this dystonic. Usually it starts in the lower limb, spreads to the upper limbs, very insidious onset. MRI will be normal, all investigation will normal. There will be positive family history in some of the cases. But if this is the scenario, always try dopamine and see how the response. It's a wonderful drug to. It's called as a dopa responsive dystonia. So clinical clue is a normal MRI and a severe dystonia in a normal appearing child prior to the onset of dystonia. Once we have finished this insidious onset dystonia, acute onset dystonia, now there is one entity called as episodic dystonia. Few examples I'll cite where there is episodic. The first video, the child is absolutely normal. It's usually seen in infancy. The moment mother picks her up, she goes into dystonic posturing. This is called as a benign idiopathic dystonia of infancy, needs no specific treatment. The second girl here, she gets dystonia when she stands up from the sitting position. When you have this kind of history, a position-induced dystonia, it's called as a paroxysmal kinesiogenic dystonia or movement-induced dystonia, well responds to the acetazolamide and flunarizine. The other dystonia where children can be normal at rest, like this girl, but once when we make her do some exercise like climbing up the stairs, and she becomes severely dystonic. It's called as exercise induced dystonia. It's a hallmark of GLUT1 deficiency. Having finished one movement disorder, the second one is this, where you have acute onset or maybe insidious onset, bilateral movements of hands and legs and maybe the tongue and maybe the trunk. So it's a 9-year-old boy who was completely normal since last 4 to 5 days, gets this abnormal movements. He also has a history of a clumsy gait and gets disturbed emotionally. So you know what it is. How these handles will help you out. See, this history from the mother is Bilal was abnormal, had a high-grade fever which lasted for a week, almost 4 months back, and had joint involvement. So you know what exactly we are dealing with. The pattern of onset is usually insidious, but here it was very acute one. You can have both episodes in Sydenham's chorea. So supportive diagnosis, this is chorea. Why this is chorea? I'll tell you the clue. Chorea means what? The word is derived from the choreography. It means a dancing. So any free-flowing dancing like a movement, whether it's in the head, trunk or maybe hands, a free-flowing movement is all, a dance-like movement is always chorea. So additional studies you ask for is a rising ASO titer, not a single, it's a rising ASO titer and a carditis or echo. It helps you to tell that this is a pseudonym chorea. So imaging is usually not needed. However, when you have other chorias, especially like this girl who had a unilateral hemichorea, always when you don't have the history of carditis or you don't have supporting criteria, always image these children, especially the hemichorea. Most of the pseudonym choreas are bilateral. You can have it unilateral, but most of them are bilateral. When you have a unilateral hemichorea, always image these children. This girl had APLA disease, antiphospholipid antibody disease. So where imaging will show you the diagnosis and according to workup. The second differential for any hemichorea, acute onset or whether insidious onset is SLE. Don't forget that. Another immune-mediated encephalitis, anti-anemia encephalitis, you can have a chorea as a manifestation. But apart from this chorea, usually these children have behavioral changes, they have sleep disturbances, they have seizures, they are mute, and the CSF shows positive anti-anemia antibodies. So insidious onset chorea, in a developmentally abnormal children, the commonest example is a kernicterus, where you can have, as I told you, upward gaze restriction, sensory neural hearing loss, MRI showing bilateral globus pallidus abnormality. The first child I'll show you had a dystonia. This child is a choreotype movement. So you can have kernicterus both in either dystonia to begin or maybe chorea at the onset. So you can have anything. The diagnostic clue is as hyperbilirubinemia in the neonatal period, upward gaze restriction, and sensory neural hearing loss. Which are the neurometabolic and neurogenetic disorder which can cause chorea? There are few, and this is pediatric neurotransmitter disorder. The clue for this is usually developmentally delayed children since birth, but have a normal imaging. So any child with no birth history, suggestive asphyxia, with normal imaging and a dyskinesia or a chorea-like movement with a microcephaly or seizure, always look for pediatric neurotransmitter disorders and do CSF and neurotransmitter studies accordingly. The close differential for this kind of presentation is ADCY5 related dyskinesia and GNAO1 disorder, movement disorder. So Huntington's disease, yes, it does present chorea, but not at the earliest, like this child. This child presented to us only with a bradykinesia and most of, clumsy gait and little dystonia, slurred speech, not chorea. So most of the, keep it in mind, Huntington's chorea usually presents as a chorea in very late disease, maybe almost 16, 18 years of illness, you will get a chorea. So the first manifestation may be bradykinesia. The clue here is this imaging. A striatal atrophy and signal abnormality in the basal ganglia tells you that probably you are dealing with Huntington's disease, and you do. So one more point you remember that WES does not, exome sequencing does not pick up Huntington's disease. For Huntington's disease, you have to do a trinucleotide repeat molecular studies different from the exome sequencing. Another movement disorder I'll talk right now is this. This girl who is 13 years old who has an insidious onset shaking movements of the hands, and everything was normal. And the clinical clue for diagnosing this disorder is obviously the history again. She gets, and the movements become worse when she writes the paper or when she becomes anxious, and there is a positive family history. So when you have this movement, this kind of movement which is more stress induced. What is a tremor? Tremor is oscillatory. How do you define it? Oscillatory movements of the around the axis of the joint, to and fro movements with the equal amplitude on both sides. That's a tremor one. Because this is essential kind of tremors where it is induced by otherwise child neurologically normal, needs no specific investigations. There are some symptomatic tremors you need to investigate, like, I'll come down to the next slide. This is again a physiological, a newborn which is extremely irritable, and the tremors disappear on holding and worsen when child is left unsupported. It is jitteriness. The drug-induced tremors are seen in early infancy, especially a child who is nebulized with salbutamol or used a lot of oral bronchodilators can have a, otherwise child is normal, can have a tremulous movements. Keep this in mind. Commonest scenario is infantile tremor syndromes. The clinical clues for this is exclusively breastfed child, vegetarian mother, chubby cheeks, hyperpigmented knuckles, skin hyperpigmentation, little bit regression of seizures, low serum vitamin B12, high MCV, The differential for this is cobalamin transporter defects and folate cycle disorders, which are metabolic IEMs. The tremors in you can have any encephalitis, whether it's infectious or post-infectious, where you have a basal ganglia involvement. The first child I showed you had a mycoplasma-induced basal ganglia changes. This child turned out to be anti-dopamine receptor 2 encephalitis, immune-mediated disorder. The imaging picture is almost same, but they developed this after febrile illness. Neurometabolic disorders which present with tremors are very early in infancy, like pediatric neurotransmitter disorder like this girl, which presented with microcephaly, global delay, tremulous movements, normal imaging, and turned out to be, I think, tyrosine hydroxylase deficient, one of the pediatric neurotransmitter disorder. The closest differential is POLG-related mitochondrial encephalopathy and spinocerebellar ataxia syndromes. Another movement disorder is a hypokinetic. Whatever movement described in previous slides were hypokinetic. This is hypokinetic. Look at the forward swooping gait. Look at the bradykinesia he has. Look at the expressionless face. So this boy was fairly okay till last 4 months. He has an insidious onset walking difficulty where he walks with a little forward swooping gait. Clinical handles for this condition was the obvious history of slowness in performing daily tasks. His speech is going down, low volume speech, onset is insidious, and the type of movement disorder is hypokinetic movement disorder. Imaging was normal, lab studies were normal. So when you have a normal ceruloplasmin copper, imaging is normal. Think of this disorder. This is called as a juvenile onset Parkinson's disease. Responds very well to dopamine supplement, and you can ask for whole exome sequencing. Which are the another hypokinetic disorder you can face in your ropidases? Very acute onset. This is very common. I have almost 6 or 7 cases of these children who had a gas geyser poisoning. The typical history is they go for a early morning bath and they don't come out. They found unconscious. They had a seizure there. Gas geyser is on. It's called as a carbon monoxide poisoning. So you do imaging, again show same thing, bilateral striatal hyperintension that I showed you in thymin biotin, responsive basal ganglia disease, mycoplasma encephalitis, anti-DR2 encephalitis, same kind of presentation. Same kind of MRI findings, but here the history gives you the clue of carbon monoxide poisoning. One of the infectious diseases which can cause acute onset Parkinson disorder is a JE, Japanese B encephalitis. This girl turned out to be JE on serology. Again, imaging is little bit same, but here the thalamus is also involved. Most of this, when you have a thalamic involvement along with the striatum, think of JE. And this girl has only 2 days of fever and encephalopathic and very bradykinetic, aphasic, mute. The metabolic disorder which can cause hypokinesia or Parkinson disease is a hypoparathyroidism, where you can have this boy, interestingly, was presented to the endocrinologist with a severe resistant rickets, hypocalcemia, hyperphosphatemia, hypokalemia, and he was referred to almost after 14 years of age when he developed this bradykinesia, when there's a mask-like face and tremors. So then we imaged him and he found to have this basal ganglia calcification, thalamic calcification, turned out to be the hypoparathyroidism. Another hypokinetic disorder where you can have a slow growing is a basal ganglia tumor. I had one case. Usually you have a hemiparesis or a hemidystonia kind of thing. Look at the right side, but look at her face. Absolutely expressionless, very bradykinetic child, no expressions, but you have a right hemidystonia. You image this child, you will have this girl turned out to have germinoma. Here was the lesion here on this with the contrast enhancement. So insidious onset hypokinetic disorder also is seen with some of the neurometabolic disorder. This girl had a pyruvate carboxylase deficiency. The clinical clues for this disorder is hypokinesia, that's number 1 with normal imaging, but they have a high CSF lactate. Always do CSF lactate in any child who has a hypokinesia. You can support your diagnosis of pyruvate carboxylase with high alanine and citrulline. And the close differential for this kind of presentation is lysosomal disorder, especially GM1 gangliosidosis, some of the Wilson disease, and pediatric neurotransmitter disorders. The congenital disorders of glycosylation will also have a hypokinesia as a presentation like this child. The clinical clues for CDG is strabismus, widely spaced nipples, and abnormal fat distribution over buttocks. Imaging will tell you cerebellar atrophy. So any child who has a hypokinesia, cerebellar atrophy, strabismus, abnormal fat distribution, widely separated nipples, think of CDG and do cyanotransferrin levels which are available at Hinduja. Next movement disorder is very common. This is the commonest movement disorder. In fact, you can see in your practice is 6 years old, has insidious onset, eye blinking, repeated lateral head jerking. Everything is normal. Birth details normal. Otherwise, children are normal. There is an urge to perform these movements. The clinical handles you look for is these movements, they stop. The child is able to stop the movements when asked to stop it. That's a clue for tick movement disorder. Usually you may have acute onset, especially if it's immune mediated like pandas and all, but most of the ticks are insidious onset, and usually imaging is not needed. One thing you remember here in ticks is a Tourette syndrome, where you have a tick duration which lasts for more than 1 year. You have multiple motor tics, either one or a more phonic tics. If you have a combination, either concurrently or at some time of the duration of the illness during 1 year, is these two combination, then only labeled as a Tourette syndrome. The last movement disorder which I'll be talking about is a simple stereotypy like this. This disorder is usually not seen in a normal children. They are usually subnormal children, autistic children, or the children with developmental delay. This is 3.5-year-old who has a repeated hand clapping movement since 9 months of age. Clinical clues, as I told you, they have usually delay, they have language delay, they remain in self. This girl, if you have microcephaly, all girls with microcephaly, language delay, stereotypic behaviors, autistic behavior, always rule out Rett syndrome. Always think of Rett syndrome, do MSCP to study. Thank you very much. I hope I am in time. That's all. Thank you very much.
Thank you. Thank you so much, sir, for briefing all the clinical clues for movement disorders. Nivedita ma'am, are you ready?
Yes, yes.
Yeah.
I'll just speak a few words. Thank you, sir, for an excellent talk. As he said, observation is very important in movement disorders. Dystonia and dyskinesia suggest basal ganglia involvement, and suggest
There's some network issue there. Sir, one question, how do you rule out functional movement disorders in older children?
That's the toughest question you can ever throw to any of the expert. Functional disorder can mimic anything. We were fooled with the functional disorder, epilepsy partialia continua. That girl was doing continuously this and turned out to be functional, So it's very difficult. Functional is very difficult to label it as. You have to observe the child and document that everything else is normal. Most of the time it is stress induced. You have underlying stress factors, but they can mimic anything. They can mimic dystonia, they can mimic chorea, they can mimic everything, tics and all. But they are usually underlying stress factors.
Do you go further in investigating children, later rule out the organic causes and then label it as functional, or if you don't find
No,
any?
not in all children. It depends upon how comfortable you are with the diagnosis of that functional disorder. If you are damn sure that no, this is functional, you have witnessed it and everything, then I usually don't. But you are in dilemma. Now, I'm not sure whether whatever she is doing. Suppose she has a leg cramp or a writer's cramp, and she's mimicking that. I don't know. So I'll observe her for another maybe a month or two, whether she shows me any other possible uh, clues to label it as a functional, and then maybe think of. But there is no fixed pattern that how long I wait.
Thank you, sir. Nivedita ma'am, please continue.
Am I audible?
Yes, ma'am. Yes.
Is my screen visible now?
Yes.
Okay,
And
sorry for all the.
it's okay, ma'am. It happens.
So, Dr. D.Y. Patil Medical College Hospital and Research Institute, Kolhapur is situated in Western Maharashtra. Kolhapur is also known as Dakshin Kashi, blessed by goddess Mahalakshmi. The D.Y. Patil Hospital is a tertiary care 710 bedded hospital spread over the area of 26 acres. The college was inaugurated in 1989 by Honorable Shankar Rao Chavan, then Chief Minister of Maharashtra, and the hospital was inaugurated in 2003 by Srimati Sonia Gandhi ji. The visionary founder president Padma Shri Dr. D.Y. Patil and the present day chancellor, the excellent leader, has taken the institute to greater heights in last 36 years. The Department of Pediatrics is the oldest and the largest department of the institute, and recently it has been renovated to a well-lit, well-ventilated, spacious facilities of indoor and outdoor patient. Our OPD complex is a 5-cubicle big complex where OPD runs all the working days from 9 to 4 p.m. with 7 specialty clinics. The pediatric ward is a 90-bedded child-friendly ward with good infrastructure for learner doctors as well. The pediatric intensive care units is a 10-bedded unit with the facilities for invasive, non-invasive ventilation, POCUS, echocardiography facilities, and peritoneal and hemodialysis facilities. The delivery rate of the institute is 2,500 to 2,700 per year, provided free of cost. The state-of-art NICU Shishu Raksha is a 30-bedded level 3 NICU with an HDU, LDU, and separate units for outborn and inborn babies and cater critically ill, premature, and high-risk infants. The immunization clinic runs daily, and we conduct neonatal screening program with the facilities for OAE, ROP screening, training, BERA facilities, and neonatal screening for common 5 metabolic diseases. We run high-risk newborn clinic for NICU graduates and well baby clinic on every Wednesday to screen babies for early developmental deviations and support. The department is backed up by a pediatric surgeon and a neurosurgeon, and nearly 20 to 25 pediatric surgeries are taken up in the state-of-art OT complex in a month. The pediatric pulmonology unit has the facilities for impedance oscillometry, pulmonary function test, allergy testing, and bronchoscopy. The NTP center in the institute helps us for managing drug-sensitive as well as drug-resistant tuberculosis cases complicated. The in-house pediatric hematologist, Dr. Preeti Naik, looks after the thalassemia daycare center. We have 50 thalassemia patients registered with us. They come for regular blood transfusion, and we provide free drugs to those patients, and they are screened for skeletal, endocrine, and cardiovascular complications under a research project, so they don't have to pay for any screening. The pediatric cardiology unit is looked after by Dr. Ravindra Pawar, who is a pediatric cardiologist with the facility of echocardiography, color Doppler, ECG for the management of critically sick cardiology patients. The pediatric neurology unit is looked after by Dr. Vilas Zadav for management of critically sick and complicated neurology patients with the facilities for EEG, NCV, EMG, and 3 Tesla MRI and CT scan facilities. We have facilities for pediatric hemodialysis and peritoneal dialysis with plasmapheresis and is headed by pediatric nephrologist Dr. Shraddha Naik and Dr. Kodi. We run postgraduate program with 9 MD candidates per year. So we have 27 postgraduate students at any given time when they are rotated in all the specialty areas. The departmental infrastructure is designed in a manner so that we can use all teaching learning methods starting from large group teaching, small group teaching, self-directed learning, experiential and hands-on practice learning. Our strength is our unique simulation and skill center, which is equipped with high fidelity as well as low fidelity mannequin with task trainers. So all our PG students undergo compulsory training of NRP, BLS, ACLS, ATLS, toxicology modules, and they are also given option of value-added courses in bronchoscopy and e-POCUS. Our center is IIP accredited for BLS training. We annually conduct BLS training campaigns outside for the police, traffic police, security people, university, nurses, and private practitioner, as well as schools and colleges. We regularly conduct community activities like menstrual hygiene program, adolescent health awareness campaigns. We also conduct every year HLA camp for our thalassemia patients. Students also learn through role play when we celebrate the national days in form of ORS and breastfeeding days and weeks. We have a very unique university moral guidance scheme, which is also called as the mentor-mentee program, where we look after the students not only in the form of academic, but their mental health and well-being for the holistic care of our students as well. We have a very strong alumni network. We have an alumni association where alumni visit their alma mater regularly and contribute in the form of academics, the patient care, guiding the students, and giving donations for the betterment of the institute. In the last 36 years since the beginning of the institute, we have come a long way, and we know we have to go a long way. But our patients who are cured and the students who shine bright in their future are our inspiration to do more and do good. Thank you for giving this opportunity. Thank you.
Thank you. Thank you so much, ma'am. I mean, your presentation showed how comprehensive care you are giving to all the children surrounding Kolhapur, involving all the subspecialties and all the high-end investigations, the allergy FOT. I think the new centers are having it now. I think you are up to date in all your subspecialty chapters also. Thank you. Thank you so much, ma'am. You can continue with the next presentations.
Thank you, madam. Now I invite Professor Dr. Suhas Kulkarni to present the research highlights in the department.
Good afternoon. Am I audible?
Yes.
Yes, sir.
Yes, sir. Yes, sir.
And are the slides visible?
Yes,
Yes, sir.
please.
Yes, sir.
Thank you. Good afternoon, all the stalwarts in the IIP. I will be presenting the research in the Department of Pediatrics. I am Professor of Pediatrics. Slide. Good afternoon. Initially, I will talk something about our college and university. Just pardon me for that. We are fortunate to have our Vice Chancellor, Dr. R.K. Sharma, sir, and he is guiding us in the research. You have heard about him. We are having IQSC Director, Dr. Shimpa Sharma, madam, who is a FAMER fellow, and she is a professor of medicine and is also doing interdisciplinary research. We are having Dr. C.D. Lokhande, who is actually from physics, but he is a research director of our university. Sir is ranked third in the India as a scientist, and he has 32,000 citations. He is having 46 patents, and he is guiding us in the research. Our dean, Dr. R.B. Nerli, is a neurosurgeon, and he is also an avid researcher. Sir has 275 research papers and has contributed to the guidelines also. DY Patil College and University has experienced teachers for research guidance. We are having a central library, digital library, which has ProQuest, Delnet, so all the international journals, e-journals are available. We are having a very good departmental library. We are having a dedicated central research laboratory, which helps us in doing the research. And we are having a center for interdisciplinary research. Then we are also having stem cell and regenerative medicine. So we can have a collaborative research in molecular biology as well as nanotechnology. Then we are also having bioskill lab, then high fidelity simulation laboratory, as madam has already elaborated. Then our university gives funding for the research up to 10 lakhs to each faculty. And we are having a research incentive policy. If we present our papers and we get some incentive for that. Then the interdisciplinary research is there, as I told you. You can see some of the interdisciplinary research which has been done along with the stem cell and regenerative medicine, like Dr. Rakesh Kumar sir's role of placental mitochondrial function in the pathogenesis of intrauterine growth restriction. So such kind of research we are doing. University and college is taking many efforts so that our undergraduate and postgraduate should work for the research. One of them is court. Our second, the JR2 is presenting the poster of his thesis, and the third year students are presenting platform presentations. We are having statisticians, then we are teaching the software. We have our own plagiarism tool like Turnitin and other things. So I will now go to the department's present publications. And as we have seen, we have a state-of-art NICU with the 30 bedded with a very good turnover. So most of our research papers are from neonatology. And the landmark paper which was there was neonatal multisystem inflammatory syndrome, MISM, associated with prenatal maternal SARS-CoV-2. This paper, you can see the date, was published in 2021. When the world was looking for the transmission of virus to the neonate, our faculty came out with an idea that whether antibodies are transmitted to the baby and whether it causes the inflammatory syndrome, which turned out to be the first paper of its kind and has been cited extensively. We are having a pulmonology department with the impulse oscillometry and spirometry. And I have been fortunate to have this paper where impulse oscillometry is an upcoming device these days to measure the wheezing episodes, the bronchospasm in the children who are below 6 years, where spirometry is not very easily available. So I have come out with the new idea that because this impulse oscillometry is not used because reference standards are not available in all over the world. So I have come out with an idea that initial resistance, which is called as R5, and after nebulization or after bronchodilator resistance, you have to minus it and actual value. And we have shown that even the results are same even when you are using the standards as well as without standards. This equation, if you use, you can come out with the diagnosis of reversible bronchospasm. I was fortunate to be part of the evidence-based guideline team of the IAP NRC, where we have come out with the guidelines on allergic bronchopulmonary aspergillosis. And in this, this was a very elaborate methodology. I will just explain in a few lines. Initially, we decide on the topic, then we go for the different questions which can be asked in that topic. Then we do the extensive search of all the databases. After that, we see the evidence by ROB, that is the Cochrane risk of bias tool for the RCTs, and NIH tool, and or the Ottawa scale for the observational studies. After that, we grade the evidence by Grade Pro, and ultimately we come to the decision by something called as evidence to decision. So this kind of a methodology is followed, and which is very elaborate, takes many times 2-3 years. So this has been published in the Indian Journal of Pediatrics. As we have already seen, we are having a cardiologist, and he is also very active, and these are the different papers. One paper which was published in the Indian Pediatrics was assessment of QT interval abnormalities on electrocardiogram in children with breath holding spells. We all think that breath holding spells are harmless, but in this paper, it was found that the pallid type of breath holding spell, the QT prolongation was there. So whenever you feel that the patient is having pallid type of breath holding, means after breath holding, if the child is turning pale and he's getting long time to recover, you kindly do the electrocardiogram of that baby, which can save the life of the baby. In hematology, we are having a dedicated thalassemia unit, and Dr. Preeti Kamble is looking after that. So she is doing a lot of research paper. So these are the different papers which she has published. In the neurology, we have already heard Dr. Vilas Jadhav, who is really a well-known neurologist and has given lectures in the many national and international conferences. So this is one paper which was there, familial hemophagocytic lymphohistiocytosis type 2 with solitary neurological presentation with PRF1 gene mutation. In PRF1 gene mutation, there is the perforin is secreted by the NK cells and type 2 lymphocytes. But in this mutation, the perforin is absent, so there is a immune dysregulation. And in this case, the patient presented only with the neurological manifestation, but the diagnosis was made and the patient was treated. Then we had our center was DY Patil Hospital was a designated COVID center. So we have come out with the COVID-19 related research papers, which you can see them. And in the COVID era, all of us know that the IAP also has come out with the letter that vaccination should not be hampered. And we have come out with a research paper that missed vaccination due in under 5 children during lockdown. And we found that 18% of the children were not vaccinated because of the fear of the COVID or the absent, the Anganwadis were not run because the staff was worried about the COVID. So these were the conclusions. Then we have come out with a lot of community-related research papers, such as adolescent social media is a burning issue these days. We can see one of the papers. Then nutritional deficiencies and the media, childhood obesity is one of them. So these are the different papers we have come out in the community. Then these are the papers in nephrology. We are also having a very good medical education unit. I am in charge of I am the medical education unit coordinator, and we have come out with the medical education research paper as well. So this was one research paper, integration of case-based learning and bedside teaching in undergraduate students, which has earned me reviewership of the medical teacher, which is the highest magazine in the medical education. Then we have also published book chapters. I have published a chapter in pediatric textbook of pulmonology. Dr. Vilas Jadhav has written a chapter in IPA textbook of pediatrics. We have 2 books published by our department. One is Bioethics Made Easy, and second is Pulmonary Function Test in Pediatric Office Practice. We are also having patents. Our Dr. Vijay Mai has come out with a novel idea of this. He has created a device that where the children with GER, if they are kept on that, if they start crying, the device rocks. So it is an AI operated device, and for this he got the Research Innovation Award by Maharashtra State, where out of 2,400 entries he stood first in that. So that was the kind of research we are doing. This is a copyright of the book Bioethics Made Easy, written by us. And we also have 2 more patents. You can see the breast engorgement relief device has already been patented, and breast milk storage device. See, when the NICU is there and a mother is admitted at some other place, we carry that milk, so that milk may get this thing. So he has come out with an idea, battery operated kind of a fridge, so which can take the milk and take to the NICU. So these are the patents. We are having university funded research projects. One of them, the RCT, which I am conducting, is we are trying to find out which are the viruses in the Western Maharashtra and Kolhapur. The second is endocrine complications in transfusion dependent beta thalassemia. The third is inflammatory markers in the neonates with the COVID positive. Our faculties are working not only locally or nationally, they are internationally. Our Dr. Ravindra Pawar has presented cases, and at Frankfurt, Geneva, and Frankfurt, these are the photographs. Our students are not behind because they get orientation the moment they are admitted in our MD pediatrics course. And a full-fledged research methodology workshop is carried out where they are given all the details about right from the literature search to the how to analyze and statisticians are there to help them. Then all the students undergo basic course in biomedical research as there is a rule. So we carry out this different activity code, that is campaign on university research and training, in which I have already explained that our second year students will present poster and third year students will present platform presentation of the thesis. Our students have brought very good laureates to us. This is Dr. Anjali, who was selected first prize, who got the first prize in Neocon, MahaNeocon 24. This was our student presenting in the RespiCon 23 on the platform presentation. And not only our students, our alumni are doing research and they are sending those papers to us because of the kind of environment which we have. So this is one of our past student, Dr. Meenakshi Balwani, got this paper published in Annals of Child Neurology. And on the top of that, our student, Dr. Ankur Rajwamshi, who is working in Bangalore in NICU, has come out, was a part of this trial, hypothermia for moderate or severe neonatal encephalopathy. And this paper is published in Lancet, which you can see that it was published in the Lancet. So thank you very much for the patient listening. And I thank IIP and thank Dr. Nivedita Patil for giving me this opportunity. Thank you very much.
Thank you, sir, for the presentation. Now we'll go ahead without wasting time. I invite our PG student, Nutan, to present his case. This is just a short case presentation.
Madam, 1 minute. Heartiest congratulations, Kulkarni sir. It covered, I was just seeing every aspect of the
can't hear
scientific session, every aspect, every system was covered in the thesis. Social pediatric, cardiology, respiratory, everything, feeding, breastfeeding, and all aspects. So really, this is an exemplary. This is an example for others to follow. This is great, great. Congratulations.
Thank you, sir.
Thank you.
Am I audible?
Speak loudly.
Oh, we are not able to hear.
Yeah, speak loudly.
Not the presenter view. Slideshow.
Am I audible now?
Yes. Continue, Dr. Mata.
Hello.
Yeah, please continue. You're audible.
Am I audible now?
You're audible. Please continue.
Yes. Is my slide screening there?
Yeah.
Good afternoon, everyone. This is Dr. Nutan Sai Parchuri, third year resident of Department of Pediatrics. I am here to present a short and interesting case admitted in our hospital. A 12-year-old girl child born out of non-consanguineous marriage referred from outside hospital with complaints of fever since 15 days and complaints of swelling in the both knee joints since 15 days. And there is history of 2 episodes of GTCS with the first episode on day 3 of illness and the second episode on day 12 of illness. And there is complaint of breathlessness since 3 days. Here there is both neurological involvement and respiratory system involvement with musculoskeletal involvement is there. On examination, the child is conscious and irritable with the febrile temperature of 101 degrees Fahrenheit with heart rate of 112 per minute of respiratory rate 42 chest rates per minute, both tachycardic and tachypnea with peripheral pulses is well felt with BP of 100/70 mm of Hg, which is less than 50th centile, with saturation of 98% on high frequency ventilation of 18 liters per minute. On general examination, there is moderate pallor. On systemic examination, on respiratory system, there are subcostal retractions with the left-sided core crypts with the right-sided inframammary crypts. On per abdomen examination, liver is palpable 8.5 centimeter below right costal margin with smooth surface, soft to firm in consistency with liver span of 13 centimeter. And spleen palpable 7 centimeter below left costal margin with smooth surface, soft to firm in consistency. On a CNS examination, power of the patient is 4/5 in all the limbs with normal tone, and remaining CNS examination of the child is normal. On CVS examination, S1, S2 is normal without any murmur. And this is the X-ray of the child showing diffuse bilateral extensive haziness and with the PF ratio of 220, indicating ARDS picture. And this is the child comfortable on HFNC mode of ventilation. And these are the set of investigations. In outside hospital, these are the in the outside hospital, the HB is 7.7 with PCV of 2.5 and of total counts of 6,500, indicating lymphopenia of 14% with platelets of 2,33,000 of CRP 9. As there is multisystemic involvement, we have done RFT and LFT, which were normal. And there is as neurological manifestations were there, CSF RM and CSF CBNAT was done, which was negative. As there is fever with hepatosplenomegaly, so wheal felix and brucella were done to rule out infective pathologies, which came to be negative with sterile blood culture. MRI brain was done, showing leptomeningeal enhancement with the basal exudates. As there is multisystemic involvement with persistent fever spikes, immunodeficiency was suspected. So primary immunodeficiency panel was sent, which came to be normal. In our hospital, initially on admission of CBC was HB 6.8 with total counts of 1330, showing lymphopenia here also in 15% with platelets of 104,000, indicating pancytopenia with PCV of 21.9 with a low ESR of 18. And CRP of the patient was 3.5 with the positive DCT. And as there is persistent high-grade fever not responding to antibiotics with pancytopenia, with hepatosplenomegaly, with low ESR and increased O2 requirement in a sick child, we suspected the HLH and we have sent the panel showing serum ferritin of 10,600, which is more specific for HLH, with fibrinogen of 180, which is hypofibrinogenemia, and with triglycerides of 360, which is raised levels. And as we ruled out every causes of HLH, and as there is no infective pathology, we have sent autoimmune, we suspected autoimmune cause, we suspected SLE. So we have sent ANA profile, which came to be positive 400, but ANA has poor specificity for SLE. So we have sent anti-dsDNA, which came to be positive, which is more specific for SLE. And C3 levels were done, which came to be 90 in the lower levels of normal. To rule out cardiac involvement, we have done 2D echo showing mild pericardial effusion. On day 10 of admission, child has bilateral pedal edema and urine RM was done showing proteinuria of 2+ with urine protein create ratio of 3.46, and USG abdomen pelvis was done showing bilateral renal parenchymal disease. This indicating we are diagnosing the case as SLE. And this is the Euler criteria with the child is having fever with the neurological manifestations of seizures with joint involvement is there, hematological manifestations of leukopenia, thrombocytopenia, autoimmune hemolysis are there, and there is pericardial effusion. In immunological criteria, there are low C3 levels and there is anti-dsDNA positive. According to this criteria, our child is having the score of 34 with positive ANA. So we diagnosed the case as SLE. And immediately after diagnosing the case, we have started the child on injection methylprednisolone pulse regimen at the rate 30 mg per kg per day for 5 days, followed by tab prednisolone in tapering doses. Injection methylprednisolone was started in view of severe cytopenias with CNS involvement is there, and tab hydroxychloroquine at the rate 4 mg per kg per day we started as an adjunct to steroids. In view of persistent hematological manifestations, injection rituximab at the rate 375 mg per meter square, 2 doses were given 1 week apart. On day 10 of admission, child developed bilateral pedal edema with BP of more than 99 centile with USG abdomen suggestive of bilateral renal parenchymal disease. So we started on injection cyclophosphamide at the rate 500 mg per meter square once in a month for 6 months. We started the cyclophosphamide as the child has having lupus nephritis features. On day 17 of admission, child has complaints of irrelevant talks with nightmares. So neuropsychiatric manifestations were there. So started on tab olanzapine and tab clonazepam. As the child's general condition was improved with reduced fever spikes and improved appetite, we discharged the child on day 22 of admission with monthly cyclophosphamide injections and tab hydroxychloroquine. This is the child at present without any complications and taking monthly cyclophosphamide injections. Thank you.
Thank you, Dr. Nutan. Nice presentation by Dr. Nutan. I'm Dr. Preeti Naik. Coming to the case, she's an adolescent girl who presented with a fever and bilateral knee joint swelling since 15 days. She also experienced 2 episodes of generalized tonic-clonic seizures, also having respiratory distress. On examination, she was having hepatomegaly as well as the splenomegaly. On lab investigation, CBC shows pancytopenia, raised ESR, which indicates the inflammation. DCT was positive, which suggests the autoimmunity. Also, the urine analysis revealed proteinuria, and the USG suggestive of a bilateral renal parenchymal disease, indicating the renal involvement in this child. ANA as well as the dsDNA was positive, which was specific for SLE. In view of persistent fever with splenomegaly, with pancytopenia, and the sick child, we also suspected HLH, and that's why ferritin as well as the other parameters were saying. She was having elevated ferritin and triglyceride, low fibrinogen level, along with the clinical features which suggest the HLH. And based on the clinical presentation, lab findings, and the imaging studies, we diagnosed her with the HLH secondary to lupus nephritis. The presence of lupus nephritis, as evidenced by renal parenchymal disease and proteinuria, likely triggered the development of HLH. So this complex case requires prompt and aggressive management to control the SLE and HLH and prevent her from long-term complications. Thank you. Over to you, Suprita.
Suprita, you can continue.
Am I audible and visible?
Yes, please continue, Doctor.
I'm Dr. Suprita, third-year resident, here to present you a case of a 14-year-old male child who had complaints of fever for 4 days and complaints of abnormal movement involving all the limbs, 3 episodes on day 3 of illness with no recovery from the consciousness. So onset and duration of the illness, the history of fever was for 4 days, which was high-grade, intermittent, not associated with chills or rigor, but relieved on medication. And there was a history of abnormal movements involving all the 4 limbs, which was a generalized tonic-clonic type, and which started on the day 3 of illness, 3 episodes at the gap of 1 to 2 hours with no recovery from the consciousness, and there was no involuntary micturition or defecation. So with this complaints, the patient was referred to us from the local facility. On arrival, we found that his GCS was E3, V1 and M3 and bradycardia. On vitally, he had bradycardia, shallow breathing and hypertension, all suggesting towards the raised ICT. So the patient was immediately proceeded with the assisted ventilation and injection mannitol was given. And on examination, the patient had a decorticate posturing, moaning due to painful stimulus. On fundus examination, no papilledema was seen, no icterus, but a liver palpable of 2 cm below the RCM, and hypertonia, exaggerated dependent reflexes, Babinski and Kernick signs were positive. With all these findings, we initially proceeded with a working diagnosis of febrile encephalopathy and started this patient on injection ceftriaxone and injection acyclovir. On working up, we found that the complete blood count of the patient had thrombocytopenia with a platelet of 99,000 and the total count with a neutrophilic predominance of 93%. On the liver function, there was deranged enzymes with the SGOT of 2630 international unit per ml, an SGPT of 1550 IU per ml. The patient was positive for dengue NS1 antigen. We did a routine CSF on which we found to have the protein was 60 and the glucose 64 and the WBCs were 2, and it seemed like the raised protein was there in CSF. On CSF PCR on evaluation for Japanese encephalitis and dengue virus, it was found to be negative. Coagulation profile of the patient was normal and the anti-IgM HIV antibodies were negative. On further examination with MRI brain, the first image is showing the T2 MRI brain on an axial cut, showing the bilateral hyperintensity of the thalami with a bilateral foci of hypointensity, possibly due to the hemorrhage. The second one is the T1 MRI brain axial cut showing the bilateral hypointensity suggestive of thalamic involvement and the bilateral foci of hyperintensity, which is the hemorrhagic involvement. So after the workup of this patient, we found that he is having a acute necrotizing hemorrhagic encephalitis, and we further upgraded our treatment to injection methylprednisolone at 30 mg per kg per day for 5 days, followed by tapering, and injection tocilizumab, which is a interleukin 6 inhibitor at 12 mg per kg. 400 mg stat dose was given to the patient, and IVIG of 1 gram per kg per day for 2 days was given to the patient, along with the anti-epileptic control and control of the raised ICT. So the patient had a stomach course with requiring a ventilatory support for 15 days, and total of 2 months of hospitalization was there for establishing of the nutritional and the physiotherapeutic support. And this is the diagnosing criteria for acute necrotizing encephalitis, a reference taken from the textbook of Nelson. And our patient has fitted into all the 5 criteria of A&E. The first one being the acute encephalopathy following a febrile illness. And second one being the no CSF pleocytosis, but the raised CSF proteins. And a CT or a MRI finding showing bilateral involvement of the thalami, and the fourth one being the elevated serum transaminases. So we have excluded all other causes mimicking the A&E. And these are the references that we have taken for the patient that we have studied. So first one is the systematic review on the dengue associated acute necrotizing encephalopathy, a systematic review that was published in the Elsevier Pediatric Neurology on September 2024. And the second article is a case-based report for the treatment of A&E with tocilizumab, which was published in the April 2024 article. So though A&E has been commonly associated with the influenza virus, dengue has also been a rare cause for association with A&E. So this was the follow-up after 2 months of complete recovery from A&E with the extensive treatment by us.
Yes, so our take-home message is, any child who becomes acutely sick following the trivial febrile illness with decorticate or decerebrate posturing and signs of raised ICT with raised CSF proteins and elevated HGOT and HGPT should be imaged urgently to look for bilateral thalamic involvement to confirm the diagnosis of A&E or ANHE. Initially, the mortality mentioned in the literature was as high as 90%, and which has dramatically dropped down to a lowest of 30 to 40 with early use of tocilizumab. So the current literature mentions that children receiving tocilizumab very early in the disease phase, clearly within 24 hours, have highest chance of survival and better long-term outcome than those who haven't received it. Thank you.
Thank you, Dr. Preeti.
Dr. Nivedita, ma'am. Nivedita, ma'am, you can conclude from your side.
Thank you, Dr. Preeti and Dr. Shraddha, for moderating these cases. Both of them were actively involved in the management of 2 cases. Thank you so much. Over to you, Priya Madam.
Thank you. Thank you so much, ma'am. Request Srinivasan, sir, if sir is there. I saw his messages.
Yeah, I already posted. Okay,
Yeah,
so
request
wonderful
you.
presentation by each and every one of you, and especially movement disorders, etc. And really mesmerized. Wonderful cases presented. Only thing why I made a mention, don't mention a 14-year-old as child, because nowadays even a 3-year-old, they don't want to be called child, adolescent. Okay, that's the only thing otherwise a wonderful presentation, very crisp and short, and really both cases are very illuminating, like many cases presented earlier in other institutions. So I congratulate all the faculty and students of this wonderful hospital. It makes me feel that I have to come and visit once.
You're
Thank
most
you.
welcome, sir. Thank you.
Thank you. Is definitely one of the best episodes, I can say. The keynote address by Vilas Jadhav sir was excellent. The videos, the illustrations, and all small videos and small cases, though he covered all the movement disorders. Thank you so much. It was wonderful, ma'am. And the postgraduates, definitely the cases, I mean, spoke a lot about the care you are giving in your hospital. It's all multi-departmental, multi-subspeciality. In fact, the SLE, you had all the facilities to diagnose and for the treatment also, and even the dengue-associated acute necrotizing encephalopathy. The starting the treatment and up-to-date diagnosis and management till the child recovers. What else we need? Thank you. Thank you so much to both the postgraduates, Dr. Suprita and Nutan Sai. Thank you. And the moderators, Preeti Nayak and Dr. Shraddha. If any comments?
One more comment I forgot to mention. The mother and child, the boy was walking happily
Yes,
after the treatment.
after
That
the
was a wonderful
recovery, yes.
video. Yeah.
Priya Madam?
Yes, sir. Jalil sir.
No, the best and excellent presentation. I'll start from the third one. The third one, as the student presenting, the HGOT is more than the HGPT. I definitely thought this is going to be an extra, out of liver. So that is the main pointer for the learning. Number two, in the second case, in the MRI, they mention about the basal exudates. Basal exudate was there. I don't know, maybe this is one of the, like a mild pericardial effusion. The basal exudate also is a part of the SLE. And the movement disorder, the same Priya Madam question I have to raise also, the functional disorder. Many times you are fooled by the patient. So excellent, the Kolhapur team, and congratulations.
Thank you, sir. Thank you.
Madam.
Yes, sir.
Yeah, madam. First of all, congratulations to you, Amol Pawar sir and CIAP. Madam, can we get this recording? How to get the recordings for our postgraduates, na?
It is there in the YouTube, sir. It is there in the YouTube. You
So
can
we can
access.
just forward them this.
Yeah, yeah.
And madam, we will request Neelam madam also next year to continue, madam, next year. Because once a month is everyone can attend. You Amol sir, nahi, it is true, Srinivasan sir, Jalil sir. Next year we can continue. This is very educative program. Very, very,
Yeah,
very
Pramod joke is being missed as well
Yes,
as
we are missing
Chinnappa, Deputy
Jagdish
Chinnappa.
Chinnappa sir
We
and
are,
Pramod Jog sir.
madam, we are missing Pramod sir and
He lost
Jagdish.
his he lost his senior he lost his elder brother.
Yeah,
So he is not there.
he
mostly.
messaged. He was ready to join, but in the end, some messaged unable to.
We missed
And JC sir is also held up with the talk, so he couldn't.
Yeah.
Rajshekar sir, you wanted to tell something.
Please continue this event. Thank
Yeah,
you.
yeah.
Rajshekar sir.
Yeah, academics is
Ramakrishnan sir. Ramakrishnan sir.
We want to listen Ramakrishna sir also.
Nice, madam. We'll keep it up as Dr. Devendra sir was telling. India having a good academics spread
Thank
over
you.
to other states.
Thank
Thank
you.
you. Thank you.
Ramakrishna sir,
Ramakrishna sir.
you have.
Good evening, all. It's a wonderful session. Really, not just because that I was asked to talk about it. And the movement disorders is really very good and educative. And the faculty and postgraduates, they have done a wonderful job. Every one of them are very assertive, to the point, crisp and informative. And long live this sessions on academics with institutions. Thank you.
Thank you so much, sir, for your wonderful feedback. I now request our coordinator from West Zone, Dr. Amol Pawar, who is also the Joint National Coordinator of Action Plan of 2025. Request for your vote of thanks, sir.
Amol is Anmol. Anmol. Amol is Anmol.
Thank you, Priya ma'am. So it was a very nice session. Actually, Basavaraj sir visited, I think, last year for the inauguration of simulation lab at DY Patil, and Dr. Nivedita ma'am, Dr. Kashmiri were there accompanying him. And at that time only I heard about the institute, and it was very nice presentation by Dr. Vilas Jadhav sir. He is very famous pediatric neurologist in that part of the Maharashtra. And also the seniors like Dr. Suhas Kulkarni sir, then Dr. Nivedita ma'am, and both the PG students, they were very crisp in their presentation. And overall, this program was very well appreciated by all the seniors, Sarin sir, Srinivasan sir, Jalil sir, Rajshekhar sir, and Ramkrishna sir also. So we missed today Dr. Our Jagdish Chinappa sir also. He was busy, I think, in another program. So it was very nice session. Thank you, the DY Patil team. Thank you, Priya ma'am, and all the dignitaries for gracing this, and all the attendees and all PG students of various institutes across India. Thank you, one and all. Thank you.
Dr. Amol. Request all to join for our next session on 20th June. Please do join. We are coming back with another prestigious institute. And once again, thanks from the CIP team and the team of Academics with Institution to Professor Rakesh Kumar Sharma sir for being the chief guest for today's session. I thank Dr. Nivedita Patil ma'am for coordinating so well, Dr. Mohan Patil sir, Dr. Suhas Kulkarni sir, Dr. Vilas Jadhav sir, and Dr. Preeti Nayak and Dr. Shraddha for moderating, Dr. Suprita and Dr. Nutan Sai, very well presented. And congratulations to both the postgraduates. Thank you so much, ma'am. And I thank our backup team of technology, Saji, and the others. Thank you so much for all the support. Thank you, ma'am.
Thank you, Priya madam.
Thank you,
Thank you
Rakesh
very
sir.
much. You're very particular. I remember last time all the 50 episodes were completed by Priya madam.
Right.
This is really
all
she
the
is
efforts
wonderful.
of all the team members, sir. Otherwise, it's not possible.
That is true. But anyhow, there must be a person who can. You are doing such a wonderful job. Let us appreciate it. Thank you.
Thank you, Rakesh Kumar
And
Sharma
Srinivasan
sir.
sir, Amol is also very particular. He will be there.
Yeah, I know.
Sometimes
So
late.
I have been there in the Maharashtra, this thing many a times. And
thank you.
Thank you so much. Devendra sir was totally mesmerized by presentation.
See, on behalf of the university, I invite you all to visit our institution and the university at Kolhapur. Thank you very much.